So now we're going to talk a little bit about PJK. So PJK is what keeps me busy as a researcher, because we didn't solve it yet. So this is our disclosure. And I'm mainly going to talk about PJK in the context of adult spinal deformity. So adult spinal deformity, as already presented by the previous speaker, if you apply like the SRS criteria, everybody that is like over 60-year-old has some form of deformity. Of course, it doesn't mean that we need any treatment, but the incidence is going to grow because we're getting like older and older. And it's a complex pathology because you can have a deformity in the coronal plane, in the sagittal plane, in the axial plane, and quite often everything is combined. And it's not just a problem of bony malalignment. It involves also like all the soft tissue, from the muscles, the disc, like the ligament. So it's a chronic condition. We know that surgery can help, but we also know that surgeries, those big surgeries, they are associated with a very, very high rate of complication. And one of those complications is PJK. So what's PJK? So it's an adjacent segment problem. It happens at least to 40% of adult spinal deformity patients. So we're not talking about like a very rare problem. It's like it's all over the place. And it's quite rapid in the sense that within 3 months after the surgery, you already see the PJK. It at least like 60 to 70% of the case. It's quite rare to have a delayed PJK. The vast majority is like, sometimes even just like the patient stand up, you already see the PJK. And if the PJK evolve, it can only go one direction, which is the wrong one. It can only go worse. Never seen like a PJK correcting by itself. And it's a little bit complex because so we usually like to focus more on the bone fracture, so the bone collapse. But more and more, the type of PJK that we see is more a soft tissue problem. So a failure maybe either of the disc or probably more often of the ligament. We also see some PJK that are due like to the failure of the implant at the junction with the vertebrae. So what do we know in terms of risk factor? So there is multiple. From a patient point of view, we know that age and the quality of the bone is a risk factor. From a surgical point of view, we know that if you extend your fusion to the pelvis, if you do an anterior-posterior procedure, if you do a large correction, if you have a very stiff construct, those are all risk factors. And we know that alignment, some of the alignment are risk factor, but the literature is a little bit confusing. Because if you look at the literature in terms of alignment, what do we know? We know that overcorrection is a risk factor, but undercorrection is a risk factor. So basically, the literature is telling us that, surgery is a risk factor for PJK, and that's the only thing that we're sure of. So what I want to do is I want to give you an update of the different areas that we have been investigating to have a better understanding of what is going on with those PJK. So the first one will be in terms of alignment. So I've been talking over and over of this concept of age-adjusted alignment, and so we try like to apply this concept to have a better understanding of PJK. But before doing that, we created, based on patient, what we call a virtual spine. So let me explain you the problem that I'm facing. You have a patient, you do a surgery, maybe a beautiful surgery, and then the patient develops PJK. Then you take an X-ray. So what you're measuring the result of the surgery plus the PJK. And since the PJK happens quite early, sometimes we never ever have a chance to measure the result of the surgery without the PJK. Because, PJK within a few weeks, a few months already appear. So you take an X-ray, you wait for the patient not to be in pain anymore after the surgery, and bam, they have a PJK. So now you take the X-ray where you see the impact of the PJK. So the trunk moves forward because of the PJK. And to compensate for the PJK, the patient retroverts. And that's what we're measuring to look at like the result of the surgery. But it's totally wrong because we're measuring two things, the surgery and the PJK. So we did a mechanical model where in fact we can remove the PJK virtually and see what will be the alignment of the patient without the PJK. Okay? And if you analyze that, so there will be like basically analyzing this image instead of this one. What we found is that overall, the patient with PJK compared to those without PJK, they do have a bigger correction. So the lordosis is bigger, the pelvic tilt is smaller, the SVA is more negative. So you're like, oh, you know, because if you do the measurement here with the PJK, you don't see that. You don't see that. You know, a lot of studies are going to tell you like, this is the same alignment, but it's the same alignment because one of them has the PJK. So it's like you overcorrect the patient and they want to go back to a position that is more comfortable for them. So they try to come back and they break at the junction. So then we apply like the same principle, but now by combining different concepts. So again, this virtual modeling when we remove the PJK, and now we looked at how far the patient is from its age-adjusted ideal alignment. And look at this graph. So the tiny bar are the patient without PJK. This means that the patient that did not have PJK, the alignment was the same as the guideline, and the guideline being age-adjusted. The patients that have PJK are here, and the patients that have PJF is the light gray. So what do we learn from that? We learn that the severity of the PJK increase as you increase your correction. And it's like, I mean, it's super, super clear. That means that maybe PJK is not just like, oh, I was not lucky. Maybe PJK can be seen as a failure of targeting your age-adjusted alignment goal. So let me show you an example. Here you have a patient, I mean, a huge PJK. Look at the plumb line. The plumb line is almost perfect. So if I don't show you the film, but give you the number, like, you know what? I did a good job. My plumb line is over the sacrum. But let me show you what we did. Now I'm going to remove the PJK. That would be the plumb line without the PJK. So you see, like, it's a little bit tricky to analyze the post-operative alignment. And so we really think that PJK can be seen as a compensation in the setting of overcorrection. If you fuse from here to here, you only have a few vertebrae to compensate. So, you know, you come back. So if you come back and you increase your kyphosis over like 7, 8 level, we're like, wow, that's a restoration of the kyphosis. Everybody is like super nice. But if you do that over 2 segments, it's a PJK. So let's keep going. There is this question also of UIV loading. So again, we develop a model where we can estimate the effort at the UIV. And what we found, and is like, you know, common sense, is like once the patient starts to develop PJK, so the upper part of the trunk move forward, and then you have the weight of the head. You have all this weight. This weight creates a bending moment, and this bending moment deteriorates the PJK. So once you have a PJK, you're starting to have a vicious circle where the PJK angle is going to increase, so the bending moment is going to increase, so the PJK angle is going to increase. And it's just based on mechanics. So think about like you have the weight of the upper part of the trunk and the head, and that creates a negative impact on your UIV. So one trick that we found is that from a UIV point of view also has to do with the bending of the rod. So we realized that in the upper thoracic spine, now, if you bend the rod in a kind of like to create the kyphosis, you're less likely to have a PJK than if you have a straight rod. and like a very, very straightforward. For the same regional parameter, the end level of the rod is quite important. Now a little bit about soft tissue. So what do we know? We know on one hand that following like an open procedure, you have a denervation of the muscle. And this has been demonstrated in several studies. So not only, I'm not talking about big surgery, even like after like a few level. For example, like in these studies, they demonstrate like 7% of decrease in a muscle volume due to the denervation. So if you apply that to our adult spinal deformity patients, the adult spinal deformity patients, they already started with very poor muscle. In a study that we did based on MRI, we found that there is more than 30% of fat infiltration in the spine erector. So already the muscles are bad. Then if you do an open procedure, you have a denervation, so they're going to be even worse. And we expected those muscles to be active at the junction, so to prevent like the spine to fall over the UIV. So in the study that we did based on CT scan, so the beauty of CT scan, and people do not necessarily realize, is that you can not only use the CT scan to evaluate like the bone quality, so using the Ausfield unit, but you can also use the Ausfield unit to evaluate the fat infiltration, and you can quantify that. Versus an MRI, it's just like visually. So what we found with this study, we found that the fat infiltration in the erector of the spine, and of course, like the density of the vertebral body, were both predictor of PJK. So think about it. We have bad muscle to start with, and then we denerve them with an open procedure, and we know that they're not going to act, they're not going to be able to hold the spine. So higher fat infiltration and lower bone quality lead to an increased risk of PJK. And so there is this new trend of using like soft tissue augmentation. So basically the concept is like to use some type of ligament. So some people go sublaminar, some people go through the spinous process. So it's still quite early. You know, it's been started maybe, I don't know, 3 years ago. Maybe Chris Ames talk about that. I know that some people in France do that, and different people have different technique, because the technique is not ready yet, but the principle will be like, you know what? You have your spine, you have your screw, your rod, and then you have the rest of the spine that is not instrumented. What if we create a gradient of stiffness by putting something that is not as stiff as a rod between like the rod and the spine, and maybe this can be seen as ligament supplementation. So the early results demonstrate that this helps in decreasing the rate of PJF, not necessarily like the radiographic PJK, but at least if we can prevent like the dramatic PJK, it's a step towards the good direction. And the last concept I want to talk about is like the flexibility of the spine. So flexibility is usually like a very good news. You know, you see a patient with a deformity. If you do some measurements, so for example here on the MRI, you can see like the spine is flexible. Then you're like, okay, you know, it's not going to be as difficult as it looks on the X-ray. But flexibility can also be tricky, mainly when it comes to the thoracic spine. So at HSS, what we do for all of deformity case, we also take a supine X-ray before the surgery. And so that on the supine X-ray, we compare like the supine measurement with the standing one, just to see like, is it flexible, yes and no. And we found, and this was not the purpose of the study, this is an accident, this finding. What we found is that patients with a flexible thoracic spine had more PJK. And we were like, why? You know, it doesn't make sense. So we dig a little bit more, and that's an interesting story. So by flexible thoracic spine, I mean like you go from something with kyphotic to something flat when you lay the patient on the table. So what happened, we also did some measurement based on the X-ray during the surgery, is that thoracic spine is flexible. You put the patient on the table, thoracic spine is flattened. put your screws, put your rod. Now you created a flat thoracic spine. A flat thoracic spine is like putting the patient backward. So remember what we said about like the overcorrection? So what could be a good news, like, oh, it's flexible, it's going to be easier. Actually, in this specific case, because we didn't realize, like, was a risk factor because we were flattening all our thoracic spine and therefore, like, pushing the patient backward and increasing the risk of PJK. So this is, for example, an example. So an old patient, she's like 79 years old. I'm going to go very, very quickly because I'm running out of time. See, like we do all the measurements, so a large thoracic kyphosis, a mismatch that is quite acceptable, mainly for this age. Like the problem is more in the thoracolumbar junction. Then, if I don't give you the age of the patient, you will say like, wow, it's not bad. Not bad, but it's actually a disaster. It's actually a disaster. Look at, you know, if I compare to what should be the alignment based on the age. Now, I have a negative SVA of minus 30 millimeter. An 80-year-old can tolerate plus 60 millimeter. Look at the PILL, minus 20. So this is like a pure classical case of overcorrection, and without any surprise, patient need to come back. There is not a lot of way for this patient to come back. It's only like the free segment, so it's coming back and develop PJK. So I think like there is a lot of opportunity like to decrease PJK. One will be like, you know, the age adjusted, but maybe at one point we need to go to frailty adjusted because age is just chronological and doesn't work for everybody. Maybe we need to think about like preserving the muscle or at least augmenting the muscle, and think about some instrumentation that are not as stiff as putting like 2 screws in each vertebra. Thank you.